I would like to continue, and I know we are late and we have to make up some time. I certainly appreciate being back at GIS. It's always a pleasure and always an honor to be here, to see my friends here. The topic of my talk, switch gear a little bit from the mitral to the aortic, the lifetime management of aortic valve stenosis, and I would like to give you some future perspectives. These are my disclosures of some relevant financial relationships. And I would like to start with the roadmap of my presentation. I would like to start with expanding patient population, both by age and by indications. Obviously, as we move along with the success that we have with TAVR, this is obviously a very important topic. The second very important one is obviously durability and long-term TAVR trial results, because it's a long history a successful history with TAVR, and the question of durability obviously comes up when we talk about new valves, but also when we talk about the beginning of TAVR, when that was questioned by the surgeon. And finally, something that we have to deal with on a long term is redo TAVR and repeatability. So I'd like to start with the expanding patient population, looking at age and indications. And this is the situation recently published from the United States, and you can see age less than 65. TAVR rose from 19% to 52% from 2016 to 2022. You can see on the left side, the age group below 65 is increasing with TAVR, and the age group of 65 looking at surgery, it's decreasing. This is not only in the age group of 65, below 65, but also up. The up situation is relatively clear and has been an indication. The less than 65, however, is in question. And we can see here the US situation. More than half of the patient aged less than 65 receive a TAVR valve. This is quite surprising, and I don't think this is shared with the rest of the world. We know in Europe, here the example of Germany, this is quite different because the number of low-risk patients definitely treated with TAVR increased, the risk went down, we get a little bit more aggressive, and the number of TAVR procedures increased looking at the STS score. However, the patient age really has not changed much. Both in Europe, here the example in Germany, has not really changed with the age group. We still treat, for the most part, patients in their 80s. The number of lower ages, meaning less than 80, 75, is increasing, but not the same amount that in the United States. So we do know, and we do have to recognize geographic differences in age groups treated with that particular technology. Then, of course, something that's very challenging, very important, and it is a moving target, actually. The extending indication, asymptomatic and moderate aortic stenosis. This is a conundrum, and the question is, why are we targeting them? Obviously, it's a natural proceed, once we have a successful technology, to not only treat the extreme and high-risk patients, but also go down the risk group. But also now we're looking at grading aortic stenosis. By the way, that's happening with aortic insufficiency also. But moderate and asymptomatic aortic stenosis has been a target for quite some time. Why are we looking at that? We're looking at that, and this is circled, because there's a huge discrepancy in the mortality rate between the patients that have received a valve and the patients that have not received a valve. This is a huge gap, and actually we have to close that gap. We have to see that we treat more patients with moderate or asymptomatic aortic stenosis. If you look at the green, mild aortic stenosis, mild to moderate and moderate aortic stenosis, that is a group that's definitely undertreated, and we have to look into this more carefully. We know that have been two trials now, the TAVR and the TAVR Unload with heart failure. This has been recently discussed, very controversial discussion, but we can see here the clinical takeaways. If you look at the asymptomatic severe AS, all tested with appropriate exercise tests, rather sooner than later, TAVR will be indicated and needed. I think this is a general message if we look at asymptomatic aortic stenosis, and particularly looking at the recent trial results. Also, if we look at the indications for clinical practice, as soon as severe asymptomatic aortic stenosis is diagnosed, the workup, including CT, and most importantly CT or even MRI, is very, very mandatory. And I think this is the message that we learned in asymptomatic severe aortic stenosis. Moderate aortic stenosis, unfortunately, the trial that was published and discussed at the ACC had to overcome some hurdles which were not intended by the investigators, but nevertheless, the results were promising but not very definitive yet. I think with learning from that particular evidence in moderate aortic stenosis, frequent follow-up is mandatory. We cannot say more after the trial result is up. More evidence is needed both for surgery and for TAVR in moderate aortic stenosis. We do know early surgical results, knowing that surgery, the patients receiving surgery are in favor of watchful waiting, but that was only small trials. So now we are looking at larger trials. More evidence is needed and more evidence is coming. Here you have a summary in asymptomatic severe aortic stenosis, the TAVR, basically surgery and TAVR versus watchful waiting. And easy AS, easy aortic stenosis, easy AS, basically the same surgery, TAVR versus watchful waiting, something that has to clarify and be clarified on a forward-going basis. In moderate aortic stenosis, obviously two important trials with balloon expandable valve and self-expanding valve. The PROGRESS AS, balloon expandable versus clinical surveillance with a balloon expandable device, basically SAPIEN, and then the EXPAND TAVR 2 with a self-expanding valve, less patients. And we were looking forward to the final conclusion. The primary completion of the PROGRESS AS is 2029, which is quite some time, and we have to deal with this now forward going. The results of the EXPAND 2 TAVR 2026 is a little closer, and hopefully we have some clearance on that. Looking at durability and long-term TAVR trial results, this is an everlasting discussion and will be everlasting between the two then competing approaches, surgery and percutaneous. But what means durability and how is it defined? Let me add, before we continue, basically, I believe, very smart word by mentioning this phrase by some of our colleagues, durability can only be proven by durability. All the new valves that are coming up claiming this is in favor of durability is hope. And probably this is true, and this is what we had to deal with when TAVR started. As you recall, at least the ones that have been involved in the early days, there were the attacks by the surgeons saying, well, it is crimped, it is bovine, it is thin, you crimp it, it's not going to last. Well, it has proven to be wrong. Basically, this is something that we have to deal with. Bioprosthetic valve generation in favor is not a sudden event, and that's the good thing. It is not sudden like thrombosis where you have to act quickly. It is basically an evolving event over time. It starts with degeneration, with hemodynamic deteriorating, and then eventually hemodynamic failure. So this is, even though it's bad, it's the good part. It is not a sudden event. We also know that this is multifactorial. It has patient-related factors, prosthesis-related factors, and procedure-related factors. An ideal THV should replicate a healthy aortic valve going through 40 million cycles per year with unfaltering function. This is what we claim, this is what we want, and this is how it is basically defined. We also know now, as we move forward in this success story, that we have to look at the very first valve that we're trying depending on the patient's age. We look at valve performance, we look at optimizing the procedure once we implant the first valve, and then of course the physiologic alignment, commissural and coronary alignment, something that is state-of-the-art that's been discussed today during the live cases. This is today state-of-the-art, and this is what we have to do because we're dealing with lifetime management as we move into younger age groups. Eventually, this is something that we have to deal with in the future. New bioprosthetic valve platforms will be introduced and tested with hopefully improved durability profiles. Here again, hopefully improved profiles. That's what we try to improve. And on the right side, you can see in red and in blue, the number of TAVR and surgery in red is increasing. And in blue, the number of TAVR and TAVR will naturally also increase because bioprosthetic valves at some point will degenerate. How do we ensure durability? Well, we try to improve deployment accuracy and ease of use by new repositionable systems or balloon expandable systems, continued advancements, advanced stenting, torqueability, depth control, and low-profile materials. So the material and procedural progress has to be taken into consideration. Long-term trial follow-up and bench testing obviously is natural and it is required. As I said, durability, some words of caution. Everybody can claim everything, but only time will tell. You all know the MitraFold story, and that is something important. Longest follow-up of landmark trials, TAVR versus surgery. We can say long-term results of low-risk trials showed superiority in case of Evolute, non-inferiority for TAVR compared to surgery in the partner trial. This is very, very good news. If we look at the lifetime management in Notion 2, we see something very interesting. In tri-leaflet valves, basically surgery and catheter approaches are similar. In bicuspid aortic stenosis, that has to be changed and that has to be further investigated because in the catheter approach, PVL and stroke are increased, disabling stroke is increased. This is the good news. Across the valve, meta-analysis, severe SVD and bioprosthetic valve failure, very low numbers, very good results, and very promising moving forward. And the last but not the least, redo TAVR and repeatability, something that's being discussed. Obviously, this is what you've seen before, the valve and valve wave. It is going up, and as we move along, 5 times more procedure in valve and valve procedures are being used and investigated, basically both surgical valve and bioprosthetic valve and valve after TAVR. The main concerns obviously are summarized: PPM, coronary obstruction, AV gradient, and of course thrombosis with reduced leaflet motion, something very important. That's what we have to look at. And if we look at the decision-making process, I don't want to go into the details. You've seen this before, and I think it is very important that we look at the patient selection carefully, at the pre-procedural planning very carefully, and of course, looking at the procedure. All these points are very important. Actually, they're more important as we move forward. If we look at the valve and valve procedure, if the first intervention is surgery, data that have been collected by Giuseppe Tarantino, if the first intervention is surgery, clearly the second intervention speaks in favor of surgery, thumbs up in green on the right side, looking at mortality. If the first intervention is TAVR, the same is happening. On the right side, TAVR and TAVR is actually in favor of the TAVR explant. The first cut is the deepest. TAVR will likely be the most frequent second intervention in a lifetime management, and TAVR repeatability might be as important as leaflet durability, something that we have to keep in mind because some interesting data are coming up. Here is the current evidence for redo TAVR versus TAVR explant. What are we doing? Explanting the valve or doing a valve-in-valve procedure? Clearly, also here speaks in favor, looking at the mortality. But new data were coming out, and you can see here at redo aortic valve interventions, time to re-intervention on the right side, analysis of redo versus explants published by Gilbert Tang. There is not so clear looking at the mortality. So we have to be a little bit careful depending on what the reason and what the etiology of the redo TAVR actually is. This is an important slide because background mortality is not interventional risk. It is driven by long-term outcomes, something very important and that you should keep in mind. What else is important in redo TAVR? Leaflet modification methods. We've seen that the slicing, many new devices are underway and under examination. And of course, neoskirt, leaflet overhang, index expansion, all these points are very important as we look into the TAVR and TAVR approaches. So finally, what is the key message for lifetime management of aortic stenosis? TAVR expands to younger patients. Patient selection is key. Durability concerns will remain. Long-term follow-up is essential and needed. TAV and TAV will become more common. Procedural planning is critical and asymptomatic. And moderate aortic stenosis, earlier treatment strategies are actually evolving and are very important. With moderate aortic stenosis, we have to still prove it in the larger trials. And finally, my projection as we move forward, longer-term management of TAVR patients will improve with the ability to monitor patients from home with minimal disruption to their daily lives. This technology, along with improved home care pathways, will allow a greater number of patients to discharge to home. With that, I would like to thank you very much for having me, and thank you. Have a successful meeting.
Thank you so much, Dr. Grube, for this nice review. I don't know if any panelists will have questions, or if you have any questions from the audience.
Thank you, Rob, for this excellent overview. May I ask a question? Still, I have concern for patients with young age, for age of 50 or less than 65, 50 or 60 now. So should we say goodbye to the mechanical valve now?
Yeah, this is obviously a very important question, and to be very honest, that's why I kind of started with the US and the rest of the world. Because, you know, I have experience in Asia and Korea, China, not so much in the Middle East, but also in South America and Europe. We are not going into the 60, 65 age group because, number one, we don't have any data. Number two, I think as we move into younger ages, obviously we have more bicuspid aortic stenosis patients, a little bit more in different regions, but this is very important. We should keep that in mind. The question whether TAVR and bicuspid aortic stenosis is the way to go remains to be seen. I know we're doing it every day because it's so convenient. Doing it, it's just nicer. But what the long-term outcome is, I'm not sure. I would, in my practice, would not recommend the patients less than 65 going to TAVR. I would much rather ask my surgical colleague to optimize a surgical procedure, and then when the patient eventually, or the valve eventually might degenerate, then I would move to TAVR. Starting with TAVR, I know it's convenient. It is, well, I mean, we are interventional cardiologists, and depending, we're moving forward. We are kind of aggressive. We have this kind of aggressive mood in our head because it's so easy and so convenient, we tend to do it. But I think we have to be careful. With all the success that we had in TAVR, we still have to be critical as to what the long-term outcome is.
Eberhard, good to have you. Nice talk. You see, for asymptomatic severe AS, we know the American approved for asymptomatic severe AS. How do you see it in Europe, and what's your plan in Europe? Are you going in the next guideline? are you going to include it or you depend on your surveillance? Because we know from these trials that at the end of the day, it's how much your surveillance is good. If you can catch the patient in 3 months, there is no mortality benefit, there is no benefit. But how do you see it in Europe? What's your plan in Europe?
Yeah, obviously, it's great to see friends here, and we can discuss this. Obviously, after, I don't know whether one of you has been at the ACC when Philippe Jeanneret came up with a positive trial. Well, we needed some positive trial. There was clapping and hello and great, great, great. On the moderate aortic stenosis TAVR unload with poor Nicolas, he had to defend the trial, which was not his mistake. It was, I don't want to go into the detail, which is actually a sad detail, but basically the trial could not have been finished the way it was supposed to be finished. So basically, I think after the excitement and the initial hype has been settled down a little bit, what is the lesson that we're really learning? And even if we look at the positive trial in asymptomatic severe aortic stenosis, let's be remembered and reminded, the difference was not in mortality. The difference was in rehospitalization, and that's the only difference. Stroke and mortality were the same. And that was only because the patients in the trial were able to be receiving on the switch over from asymptomatic conservative to TAVR in a very rapid time, basically 30 days. That is why there was no mortality difference. Now, you can claim if the time between the correction is longer, then the mortality would have been higher. We don't know. But that's what the trial situation is, and maybe this is not the real world situation. So I'm a little bit more skeptical that the guidelines will adapt as early as it is now. I think there will be certainly a mention and maybe some kind of classification, but I don't think it's going to be A. In moderate aortic stenosis, we don't have unfortunately, any reasons, and it will last until 26 when TAVR expand is out. I mean, when TAVR 2 with Medtronic, and 29. But 29, we have 25 now, 4 years. What are we going to do in 4 years? We all know earlier intervention is good. We know that. But how early should it really be? And that's really the question.
Can I just ask you a quick question? Along the same lines, don't you think that the asymptomatic trial in TAVR was truly positive if we were to look at it, building on the 2 previous surgical trial in asymptomatic patient, right?
Yeah.
Because it had a positive outcome. You don't think that will just follow the same outcome?
Yeah, that's basically, that is really the question. And I think we have to be fair to ourselves. It doesn't help us if we move the whole field into the wrong direction too early. We've had a success story, by the way, much different from mitral, but this is not the topic now. And so we tend to overlook many or some warning signs. And unless we have really clear signs that we're helping patients, we're not helping industry, we're not helping ourselves, we're not following our own, we want to treat the patients. We want to make sure that the patient will be helped and not our imagination. So I would still be very careful, and I will still be a little bit more sobering by all the excitement that we had. And no question, it was a very successful trial that Philip and his co-workers did, or the sites did. But a little bit of a caution, it's a trial situation. It is not the real world situation.
Thank you, Professor, for shedding light on an important and hot topic, the early TAVR. But in clinical practice, we are facing this question a lot. Well, why would you wait in a severe AS if there is documented data about myocardial fibrosis and cardiac MRI? I think it also play on the durability. But currently, do you foresee any difference physiologically when we see the young active who's asymptomatic? Why would I not send this guy for surgery if I do have a data to say sending them for TAVR was a successful data? So I'm just finding the argument again, not especially if we are trying to prevent myocardial fibrosis based on the prior MRI trials.
Yeah, so you're probably talking to the wrong person here. I still believe, and in my clinical practice, I know that we need trials to shed light on different questions. And I know that randomized trials are the fundament of moving forward in a critical field. I recognize that, I realize that, and I accept that. At the end of the day, it's the same with the guidelines. The guidelines are a recommendation. It's not a must-do thing. And my belief is if you use patient-physician relationship at the end of the day, and last week I had my own friend with moderate aortic stenosis, totally asymptomatic, at least he says he's asymptomatic, explain, what should you do? Now, you cannot have a trial, and a trial will not resolve everything. You know that. Look at cerebral protection. I said it 10 years ago. I said it 5 years ago. We will not resolve this by a trial. But looking at moderate aortic stenosis, at the end of the day, you recommend what you think is the best thing for this particular patient. I know in moderate aortic stenosis, in the case of my friend, who has, by echo data and by gradients, I would like to see MRI, and that's the good thing about imaging in these days. We do have MRI and CT where we can look at myocardial fibrosis. We can look at myocardial imaging, whether there is some damage that has not been detected prior to these sophisticated imaging technologies. But now we do. And if I see the gradient only, the opening area only, or the effective opening, is not enough. We have to look a little bit deeper into the heart. And if there are signs of damage in the myocardium, I would clearly go in favor of a TAVR. The results in 5 years might tell us something, but we have to make a decision now. And that's, I think, where imaging helps us.
Thank you.
I don't know whether that answers your question, but I don't think, patient-physician relationship is still the basis of our profession.
So, yeah, I have a question. Don't you think that the set of skills that is required from multidisciplinary team to decide or to declare that the patient has moderate AS is way much higher and sophisticated than just a severe AS? Because if you will be missing if you just do it routinely basis, you will be missing a patient with paradoxical AS, severe AS, and the low flow, low gradient AS. And if you just go with the CT scan in our group of patients here and in this part of the world, that there is some rheumatic heart disease still in there, and that's an element. So to declare that this is an absolute solid moderate AS is not an easy thing.
Yeah, I know. It's interesting. Our discussion focuses on moderate and asymptomatic aortic stenosis. That's the most important field. And there are geographic differences with here versus Europe versus the US. Definitely going into the Asian population. But I do agree with you. I mean, what can we say at this point? I don't know.
Abdullah, last
Thank you, Prof, for your nice presentation. I think while we are talking about asymptomatic patient, the ejection fraction, the age of the patient, severity of the valve, and the severity of the stenosis, which can make the difference between A and B patient, for those to go straight for thinking about TAVI, or the other one to think again and again to go for that procedure.
Well, I mean, basically, we're focusing on the same issues, and this is what is the right decision point, and how long do we wait, and what should be the recommendation. I think Also, you know, it circuits around the questions, how many new valves do we need? As you know, there are new valves coming up. Very interesting valve, claiming that will convey into longer durability. We don't know. You can claim it, but our technology will improve. Our technology will move forward. And I'm convinced that while we are successful, and you see the trend in the US, while we are successful and don't have any bad signs, we will kind of move into a indication group where we don't have strong support either by data or by long-term outcomes. And that is something that we have to be very careful about. And I don't want to be negative, by all means. I have been always positive in my life, but this is something where I would like a word of caution.
Fair enough. Adil, anything but asymptomatic aortic
No,
stenosis?
it's still the same, but my question is, the trials that we're expecting, are they blinded and are they sham controlled? Because I think that was the biggest problem for us to be able to answer asymptomatic AS. If I know as a patient that I have a tight valve and that was not treated, I know, my physician knows, and then I get everybody knows, and then I get a cough, right? I go to the emergency department, everybody knows I have a tight valve, we need to treat that. And if you look at the Kaplan-Meier curves, it was not gradual. Immediately, from 0 to, I think, 3 months, it separated very quickly. That cannot be asymptomatic AS causing the problems. That is people knowing that they have a disease, and now I need this disease treated. So I think unless we have sham-controlled, blinded trial, you will not be able to answer this question.
You're speaking out of my heart. I agree with you, because once you carry what you hear, you carry that load in your heart, whether you want it or not. This is the same with coronary heart disease. It's the same with any disease. Once you know you have it, then it is in your mind, and it will limit your ability and your activity.
And out of your heart, how would you blind this trial?
I know.
There is no way.
No, I know.
Absolutely no way to have a blind. There is no way. Everybody except maybe the patient. And at the end of the day, the patient will know. But you see, I think I cannot get away from the asymptomatic because...
Fair enough, Abdurrahman. You have to conclude that
surveillance,
beyond
I think for our area, and I need the comment from the panelists because I want you to share this message. From our area, I think the message for me, asymptomatic severe AS, only say asymptomatic when you put him in treadmill. And if you put him in treadmill, he's asymptomatic, make sure that you have surveillance and you have a follow-up. Make a group, WhatsApp group for these patients. Talk to your technology. Make sure that you get them within a month or 2 months. If you are not sure about this, you can make a case of asymptomatic AS because you don't trust your surveillance, you put TAVR for them.
I think we do it. We do stress
totally
tests.
agree.
We all do.
We do.
Yeah, we do it all. Well, thank you so much. Thank you.